Okay, so good morning, everyone. So this is QRS supervision class. So we are starting with pathology today. So pathology and pharmacology are the topics that we are going to deal with today. So these two are extensive topics, but as much as possible, we'll quickly cover them, and we will see all the important points without missing anything. So this is going to be a very short session. The total of 5 hours, 2.5 hours for each subject. So in 2.5 hours, we won't be able to cover all the concepts, but as much as possible, we'll discuss all the key points and finish up the subject soon. So the primary motto of this QRS quick reviews session is, I want all of you to know how to read this book and how quickly you can finish a subject in this book. So I think we can start now. So before going to the actual contents of the QRS, so I had to start with, I thought I can start with some key points before going into the main discussion. So these are important. Okay, so these are important. That is fathers. So in any subject, fathers are very important. So if you know these two words, that should be fine. One is Paul Ehrlich, another is Rudolf Virchow. So Paul Ehrlich is the father of clinical pathology, whereas Rudolf Virchow is the father of cellular pathology. So clinical and cellular pathology. So these two fathers are very important. So clinical means Paul Ehrlich. Cellular pathology means it's Virchow. Okay. So this is additional point. Once asked in exam, pathology is derived from Greek. This type of question will not appear anymore, most probably, because there's an old pattern MCQ. Just to know, pathology is from Greek. Now, so in pathology, the first topic is going to be a cellular level of topic, in which when a cell gets affected, because of, or we can say when a cell get damaged because of stress or toxins, so this is called as insult. So what an insult does to a cell is it injures the cell. So how does the cell respond to that insult is what we are going to see. So the cell can respond in different ways, by becoming a metaplastic or dysplastic or anaplastic or hyperplastic or hypertrophy. So these are the ways the cell can adapt themselves. So these are adaptation mechanisms that is taken by the cell in order to respond to the stress or toxic insults. So the first one is metaplasia. This means replacement of one mature cell type with another. So the key word here is mature cell type. So one mature cell type with another mature cell type. So metaplasia is mature to mature. So triple M is the mnemonic I want you to remember here. Metaplasia is mature to mature. This is an important MCQ. Then comes dysplasia. Dysplasia is mature cell type is replaced by less mature or immature cell type. So immature cell type replaces the mature cell type. Okay, it replaces the mature cell type. Then comes anaplasia. Anaplasia is cytologic features of cells which is considered to be characteristic of malignant neoplasm. So what happens here is anaplastic cells show something called pleomorphism. It shows a lot of different morphology and high nuclear to cytoplasmic ratio. So these are the two important MCQs that you need to know in this line. And then hyperchromatic nuclei, abnormal nuclear contour, prominent nuclei, and loss of normal polarity. So these are the three words from this. I want you to note down these three words: pleomorphism, high nuclear to cytoplasmic ratio, and loss of normal polarity. So these are three words I want you to note from anaplasia. So one important MCQ is the hallmark of malignancy is anaplasia. Hallmark of malignancy is anaplasia. So that is important MCQ you must note here. Now, so we talked about a very important point: loss of normal polarity. Can this loss of normal polarity be present in this metaplasia or dysplasia? In dysplasia, yes, it can be. Loss of normal polarity can be present in dysplasia, but that's not seen in metaplasia. Okay, loss of normal polarity is mostly seen in anaplasia, but it can also be seen in dysplasia. So anaplasia, dysplasia, you have to remember loss of normal polarity, but that's not seen in metaplasia. Okay, can this pleomorphism be seen in metaplasia and dysplasia? Again, pleomorphism can be seen in dysplasia, but in a lesser extent, but it's not seen in metaplasia. Okay, so these two are important points you must know. Next is hyperplasia. Yeah, next is hyperplasia. So hyperplasia is abnormal increase in number of cells, which is compared to the hypertrophy, which is abnormal increase in size of the cell. So hyperplasia, plasia refers to number of the cells. Hyperplasia, hypertrophy refers to size of the cell, increase in size of the cell. Okay, so in hyperplasia, the DNA content will be same as in normal cells. Even though the number of cells increase in hyperplasia, the DNA content will be same as in normal cells. Okay, whereas in hypertrophy, the size of the cell keeps growing, so the DNA content will get grow also. So DNA content is more than when you compare a normal cell. A normal cell's DNA and a hypertrophy DNA, the DNA content will be more in a hypertrophy DNA, whereas the DNA content in a hyperplasia, if you check a hyperplastic cell along with a normal cell, the DNA content will be same. Okay, so these are the MCQs that you must know in these topics. I hope I'm clear. I repeat one more time quickly. Okay, so metaplasia, dysplasia, anaplasia, hyperplasia, and hypertrophy. So metaplasia, you have to remember 3M. Metaplasia, mature cell to mature cell. Dysplasia, mature cell is replaced with a less mature cell or immature cell. Anaplasia means, you must remember, it's like malignant neoplasm. So anaplasia is the hallmark of malignancy. Anaplastic cells display pleomorphism, high nuclear to cytoplasmic ratio, prominent nucleoli, loss of normal polarity, hyperchromatic nuclei, abnormal nuclear contours. Hyperplasia means abnormal increase in number of cells, whereas hypertrophy is abnormal increase in size of cell. So if you see the DNA content along with the normal cell, in hyperplasia it's going to be the same. In hypertrophy it's going to be, in normal cell it's going to be of less size, less contents. DNA content is going to be less, whereas in hypertrophy cell more content of DNA. Okay, so that's it about this topic. Now In QRS, a very important point is given. That is compensatory hyperplasia. Compensatory hyperplasia. This is increased tissue mass after damage or particular resection. The patient undergoes a surgery, or a patient like after some damage, there's going to be a compensatory increase in number of cells. One example is a patient goes to a C-section. What happens after that is a lot of fat cells get accumulated in the site of surgery. So in the abdomen, a lot of fat cells are going to go. So abnormal increase in number of cells, that is hyperplastic cells. The reason is fat is essential for getting back to normal from an injury or an insult. So you could say a surgery, so a surgical insult or damage. So fat is needed for recovery. So there's going to be a compensatory hyperplasia in that place. Okay. Okay. Other than that, other terms you should know is simple atrophy and numeric atrophy. Simple atrophy means reduction is only in structural component of cells. So atrophy means reduction in number of cells. But if the total number of cells decreases, it is numeric atrophy. If only the structural component of cells decreases, it is simple atrophy. Okay. So these are all the words that you must know for cracking this MCQ. Okay. So next is cell injury and inflammation. So to start with, the most important, most basic MCQ of pathology is hypoxia. Define what is hypoxia? Low oxygen level, low oxygen delivery to tissues. Hypoxia will lead to ischemia. So hypoxia leading to ischemia, because hypoxia is the most common cause of ischemia. So hypoxia itself is the most common cause of cell injury. So which simply means low oxygen means there is going to be cell injury. So these are the two different MCQs which states the same thing. Then comes affinity to hemoglobin. So hemoglobin affinity is more with carbon monoxide, more than carbon dioxide, and more than oxygen. So carbon monoxide. So hemoglobin affinity, you need to remember it is more with carbon monoxide. Then the next MCQ is 1 gram of hemoglobin carries how much ml of oxygen? 1.34 ml of oxygen. So I'm going to circle certain points. That is exactly what is needed for your MCQ. So 1 gram of hemoglobin carries 1.34 ml of oxygen. So you might be asked how much 2 grams can carry or 3 grams can carry. You need to calculate it in your examination. But mostly standard MCQ is 1 gram carries 1.34 ml of oxygen. Next, the first organelle to get damaged in reversible cell injury. We'll be talking about reversible, irreversible cell injury later, but anyway, we have to read these points. It is mitochondria. Okay, first organelle to get damaged in reversible cell injury is mitochondria. There's something called coupling ratio. Coupling ratio, that is sodium is to potassium ratio, that is 3:2. For a depolarization to occur, 3 sodium enters this 3:2 potassium and sodium. The entering and leaving point in a cell is called as the symport, for sodium potassium symport. So the coupling ratio is 3:2. Most important enzyme needed for drug metabolism is CYP450, cytochrome P450. That is the most important enzyme needed for drug metabolism. Then the next MCQ is sarcoplasmic reticulum is the source of sequestration of calcium. Source of sequestration of calcium, sarcoplasmic reticulum. Then the next MCQ is cell membrane damage is the most characteristic feature of irreversible cell injury. Then the nuclear changes that is happening in a cell injury. Reversible means clumping of chromatin and irreversible means pycnosis, karyorrhexis and karyolysis. So in this box, if you see, we have something around 11 or 12 MCQs. Now, so at least 6 six of them are from reversible, irreversible cell injury. We'll be talking about that. So the basic points that you need to carry here is, we talked about oxygen. So low oxygen level is going to be a stress factor. So low oxygen means it's going to cause cell injury. That is very important. Now, next is the carrier. So if you see, the oxygen is dangerous. Yes. Less oxygen level is dangerous. Yes. But you need to know that suddenly when a patient gets a lot of carbon dioxide in, or when a patient gets a lot of carbon monoxide in, because carbon monoxide affinity is very, very high. So it is more than 50 times to 200 times almost higher than that of oxygen level. So this is going to be a poisoning for a patient. So it is going to replace the oxygen, and it is going to make the tissue die devoid of oxygen. So how the tissue is going to die? It is going to die of hypoxia. That is ischemia. Okay. So basically, when a cell gets less oxygen, so less oxygen is delivered to the tissues, right? So that is hypoxia, causes ischemia. So less oxygen delivery. So then the tissue will start losing its life. So the tissue can break down, can cause something called necrosis or gangrene. Okay, gangrene or necrosis. So for now, this is not important. So all you need to know is carbon monoxide is more affinity. The next we saw is 1 gram of hemoglobin that carries 1.34 ml of oxygen. Okay, so we saw something about reversible and irreversible cell injury. So comparing important point is, in reversible cell injury, the first organelle affected is mitochondria. Okay, that is very important point we saw. Then in irreversible cell injury, cell membrane damage is the most characteristic feature. These two are very important points that we saw. Now, next, we talked about hypoxia. So we need to know the types of hypoxia. Hypoxia could be just hypoxic hypoxia, which means there's low oxygen tension, for example, in a higher altitude in a mountain area, or patient is hypoventilating after hearing some stressful event, or a weak mismatch, ventilation perfusion mismatch due to some issue in the lung. Okay, so that's called as hypoxic hypoxia. Then there's something called anemic hypoxia. There is enough oxygen, but your blood does not have enough hemoglobin, so that the oxygen carrying capacity is lesser. So there is anemic hypoxia. This is due to either anemia, which means the hemoglobin is already low, or it could be due to patient is having any ongoing blood loss, or it could be because of carbon monoxide poisoning. So I told that carbon monoxide will quickly replace the oxygen because it is very highly diffusible, more than oxygen. So these are the three reasons. So you don't have to memorize these three. Just if you understand, you will be able to make it. So I repeat, anemic means either hemoglobin is low. So directly hemoglobin is low because of anemia, or the patient is losing blood. So blood is lost. So patient is bleeding. So which means obviously there's going to be lesser hemoglobin in the blood. Right? Lot of blood have been already in loss. And the third is carbon monoxide poisoning. So in this case, there is oxygen, but carbon monoxide replaces the oxygen. It goes and sits with the hemoglobin. Carbon monoxide goes and sits with the hemoglobin. And this hemoglobin is going to carry the carbon monoxide instead of oxygen. They prefer carbon monoxide because it is readily and quickly diffusible. So these are the 3 points when it comes to anemic hypoxia. Then comes something called stagnant hypoxia. Stagnant means, yeah, you have oxygen is going to the tissues, but what happens here is the tissue is not taking it. So there is reduced tissue perfusion. The tissue is not the oxygen is not going from the blood to the tissue, so that perfusion is reduced. That is called stagnant hypoxia. So this is common for your MCQ. You need to remember heart failure, and the second important is shock and heart failure. So these, and then MI. So anyway, shock and heart failure, these are very important for stagnant hypoxia. The last is histotoxic hypoxia. This means the cell are not able to utilize the available oxygen. Why? The patient is poisoned with cyanide or a toxin, that is diphtheria toxin, or nitroprusside. So these these two drugs and this diphtheria toxin, these three things can cause histotoxic hypoxia. So overall, hypoxia is very important. Okay. Now coming to reversible versus irreversible cell injury. So reversible cell injury means there is an insult, the cell suffers, and the cell gets better from that suffering. So there is reversible cell injury. Whereas if it continues to get destroyed, there is irreversible cell injury. So reversible cell injury, in a reversible cell injury, so there is going to be a cellular level of swelling. Whereas in a irreversible cell injury, there is going to be lysosomal swelling.